Assalamu alaikum. Our topic today is glaucoma and refractive surgery. We are going to discuss which patient is fit for glaucoma surgery, for refractive surgery, namely PRK or LASIK. It is estimated that about 4 million refractive procedures were performed in 2014 throughout the world. In 2013, the number of glaucoma patients was estimated about 64 million, and it's expected to reach about 118 million by 2040. An estimated 9 to 28% of patients with myopia have a primary open-angle glaucoma. Since the glaucoma examination largely depends on central and corneal properties, the reshaped post-refractive surgery's cornea poses a challenge in the diagnosis, follow-up, and management of glaucoma patients. So we are going to assist the patient and see whether it is fit for refractive surgery or not, starting with the pre-op assessment, and categorize the pre-op assessment into family history, intraocular pressure, myopia, high CD ratio, central corneal thickness, race, ophthalmic disease, hypermetropia, previous anti-glaucoma procedures, visual fields, and modern imaging modalities. And we are going to discuss each in detail. Family history of glaucoma. Epidemiological studies have shown that people with familiar predisposition for glaucoma, especially the first-degree relative, have an increased risk of developing ocular hypertension and glaucoma. Moreover, these individuals tend to develop glaucoma or ocular hypertension at a younger age than the general population. The prevalence of glaucoma among siblings of glaucoma patients is approximately 10%. So we have to emphasize in the history whether the patient have a glaucoma in the family. IOP measurement. Elevated IOP remain the most important modifiable risk factor for developing glaucoma. However, single IOP measurement is not sufficient. Large diurnal fluctuation of IOP and IOP asymmetry between the two eyes is an indication of increased likelihood of developing glaucoma. Myopia is a risk factor for developing glaucoma, as we know. It is estimated that 9 to 28% of patients with myopia have a primary open-angle glaucoma. High myopia, more than 6 diopters, have a higher risk. Tilted disc and peripapillary atrophy can complicate the clinical assessment of glaucoma, glaucomatous optic neuropathy. As the modern imaging tools do not include high myopia in their database, high myopia are rather than excluded in these machines, the measurements that can provide are unreliable. So we cannot rely on OCT measurement for such patients in extreme emmetropia, because these devices compare the normal with the presenting patient. In these machines, the number of patients is already limited. They exclude the extreme emmetropia, hypermetropia, and myopia, and tilted disc have a limited number within it. So we cannot compare the result of the patient with the normative database included in these machines, which is already excluded. In these cases, the pre-op photography of the disc is of great importance. High CD ratio. A high CD ratio is a risk factor for developing glaucoma, as we know. The parameter of the disc and the thickness of the peripapillary layer of the nerve fiber layer play a pivotal role in the post-operative follow-up of patients who have undergone refractive surgery. So every patient that we have a glaucoma or glaucoma suspect or ocular hypertension should have a baseline assessment with the OCT, visual field, and photography before refractive surgery. Central corneal thickness. It is known that a thin cornea is not only a limiting factor for laser-assisted surface ablation, but also is an independent risk factor for developing glaucoma. Race of the patient. Afro-Caribbean origin, develop open angle at younger age than group and more than white people. Black people already have thin cornea. Other ophthalmic diseases, pseudoexfoliation syndrome, pigment dispersion are non-risk factor for secondary open-angle glaucoma. A study of 12 patients with a pigment dispersion syndrome shows that its presence does not affect the result of refractive surgery. The author indicate that the final refractive outcome in patients who receive topical anti-glaucoma medication before surgery is less predictable because the healing process of the cornea would be changed. Hypermetropia are more likely to have a narrow anterior chamber angle, and a case of acute angle closure glaucoma after LASIK in hypermetropic patient has been reported. A preoperative gonioscopy will help the surgeon to recognize patient with narrow angle or occludable angle. Previous anti-glaucoma procedures. Photorefractive keratectomy, the PRK, is the safest surgical option in patient with a previous filtering surgery. The creation of the corneal flap with a mechanical keratome or the femtosecond laser docking during laser may damage the already present and thin filtering bleb and compromise its function. The new refractive lenticle extraction surgery still requires docking for the femto laser operating system on the eye and should be carefully used in patients with a thin bleb. Visual field. The pre-operative visual field helps the surgeon identify the following: presence of established glaucoma, the extent of the glaucoma, and the risk for developing more glaucoma. Patients with a high PSD have a greater chance of developing a glaucoma, and it is written in the ocular hypertension treatment study, even in the absence of visual field scotoma. Consequently, the preoperative examination of visual field, especially in patients with a predisposing factor for glaucoma, is a useful tool for the future monitoring of refractive patients. Modern imaging modalities like OCT, HRT, GDX provide quantitative analysis of the peripapillary optic nerve fiber. The disadvantage is that their database, although constantly enriched, include limited number of people. The unusual disc, like tilted and high ametrope, are excluded from the database. In these cases, digital photograph of the optic disc and the comparison with the future photo will give valuable information. Intraoperative risk factor for glaucoma progression. Although the sudden increase in IOP during LASIK surgery does not appear to affect significantly the structure and function of the normal optic disc, it is recommended that PRK is the preferred method of refractive surgery in case of glaucoma. Suction time should be minimized to decrease the chance of optic nerve damage from transient increase in IOP. Alternatively, PRK or laser subepithelial keratomiliosis may be preferable because each avoid the IOP rays associated with flap creation. In rare cases in which both filtering surgery and LASIK are planned, it is preferable to perform LASIK before filtering surgery. After the surgery, what's the point that we should take into consideration? The effect on the central corneal thickness, the effect on the corneal viscoelastic properties, interface, fluid syndrome, steroid responder, corneal permeability, and topical anti-glaucoma medication. The effect of central corneal thickness, the principle of applanation, as we know, it assumes that the corneal thickness is about 520 micron. The postoperative reduction of IOP is due to thinning of the corneal stroma, change in its curvature, and the instability of the corneal flap, and the removal of the Bowman layer during PRK. However, there is not still a commonly accepted algorithm that calculates the high accuracy, the level of the actual postoperative IOP. For example, IOP is underestimated by about 5.2 millimeter mercury in cornea with central corneal thickness about 450 micron. So we cannot rely on an IOP measurement by applanation solely. Measurement in high myop is done on the periphery of the cornea, which is less corneal tissue is removed. So when we plan to follow up patient with the applanation, we have to take it from the periphery. The pneumatotonometers, the air puff, applanate a small area of the corneal surface than the Goldman tonometer. tonopair compared with the Goldman tonometer, its measurements are less influenced by the thinning of the stroma and the reduction of the corneal curvature. So, with the tonopain, and air puff is superior for applanation in postoperative follow-up of patient. Interface fluid syndrome, it is a syndrome due to accumulation of fluid between the corneal flap and the underlying stroma after LASIK surgery. This fluid acts as cushioning, which results in falsely low IOP reading as measured with the Goldman tonometer, while the IOP with other tonometer may be measured correctly high. This condition remains undiagnosed, and the IOP is not assessed correctly with different types of, if it is not assessed correctly with other different type of tonometer. Severe glaucomatous damage can occur if it is not measured correctly, and the ophthalmologist does not rely on functional tests like visual field. This syndrome should be distinguished from the diffuse lamellar keratitis, and because it does not respond to steroid, and they require treatment with aqueous suppressant. Another complication is the steroid responder. As we know, steroid responder is more in patients with glaucoma, more in patients with myopia. The international literature has shown that the use of topical steroid postoperatively can lead to a significant raise of IOP, especially in patients with the following: primary opening glaucoma, glaucoma suspect, people with first degree relative of glaucoma, diabetes type 1, high myopia, people with a previous episode of steroid responsiveness, and patients with rheumatoid disease and in advanced age. Increased IOP lead to a spectrum of clinical manifestation in the central, in the cornea, that range from simple raise in IOP to stromal keratitis, pressure-induced stromal keratitis. Corneal permeability after refractive surgery. Studies in patients have shown that the corneal permeability increased after PRK and LASIK surgery. Permeability increased in the first 2 months post-operatively and then decreased gradually from the second until the 6th month post-operatively when it returned to normal. PRK and LASIK cause non-significant increase of corneal permeability to timolol 1 month after surgery. Topical anti-glaucoma medication after refractive surgery. Unfortunately, little evidence exists about the effectiveness of topical anti-glaucoma drops in refractive patients. A combination of timolol twice daily and dorzolamide 3 times daily is more effective in lowering IOP after PRK in ocular hypertension patient compared with timolol alone or with dorzolamide alone. Latanoprost and timolol have the same hypotensive ocular effect in patients with ocular hypertension due to steroid responsiveness. What is the take-home message? Glaucoma is a relative contraindication. It is not an absolute contraindication for refractive surgery. LASIK is contraindication in any patient with marked advanced optic nerve damage and cupping, with advanced visual field loss and visual acuity loss. Patients should understand that the primary open-angle glaucoma may cause a progressive loss of vision independent of any refractive surgery, and that IOP elevation during a LASIK or following LASIK or surface ablation, often due to steroid responsiveness, can cause glaucoma progression. Thanks.
Thank you, Dr. Hussein, for this very important home message. Please to come here, Hussein. Dr. Hussein, please to come here. Dr. Hani, please to come on stage. Dr. Ahmed, please.